This second section is really about a blind spot in heart disease risk stratification, and that is ignoring mildly elevated blood pressures and mildly elevated LDL particle numbers.
Mm-hmm.
And this really hits home to me for two reasons again. This time, primarily driven in my own journey. So I also got a Cleerly study done. And I had a calcium score that was done, I don't know, was it a year and a half ago or something? And it was in the 40s, which is low overall, but I was incredibly disappointed, right? I mean, I was so
You're
upset.
pretty bummed about that.
Yeah, I just knew it was going to be zero. And the fact that it wasn't really messed me up. And I have been working on my own health journey and my fitness and tightening things up. And I started really paying attention to things like blood pressure and my scrutinizing some of my labs, not doing any therapeutic, no medications or anything, but I started documenting. And I got a Cleerly earlier this year because I'm like, well, if I have 46 calcified, I wonder if I have any non-calcified. And sure enough, I do. And it was really, on one hand, disappointing. On the other hand, I felt incredibly grateful. I needed to go through the grief process, and it took me a good 3-4 weeks to kind of come out the other side grateful. You know, acceptance is the last phase. But I mean, it is a singular test that redirected the trajectory of my thinking for my own health. Here I am doing all the things that I can do. There's nothing I've done to deserve the blockage that I have found in one of my arteries. Now it's mild, but I now know that I have a little something in one of my main arteries that I need to keep an eye on.
Yeah.
And as I look back over the last year and a half of looking at, well, how could this be? How could I have a calcium score of 46? I noticed, wow, I've got some mild, I mean, by definition, some mild hypertension that I'm not treating. Wow, those 10 years of working nights in the ER and not sleeping, like I'm starting to put together a narrative that makes sense to me as to how I became mildly hypertensive. And I'm a high drive guy. I'm not the best at relaxing, as is well documented. But it then allowed me to really rethink about these patients of ours that I also, by extension, tend to be a little laxed. I'm incredibly aggressive and on offense when it comes to metabolic things like insulin, fasting insulin levels, and
which yours is like 2.
Yeah, no, and I'm all-time great at that. And my patients are also very tightly managed. But there's this weird projection of laxity in my intensity and focus around hypertension, and allowing my people to walk around with, high 130s, low 140s, over 90s. And although it's not scary in the short term, it's absolutely not goal.
Right.
And so I have now started to ratchet down in my own life and treating my own hypertension. And now I'm, it's changing the way I'm practicing.
And would you have addressed a calcium score of 46 in a member of yours, I guess? In the past, before Cleerly. Maybe.
I would have immediately gone to, well, what's the metabolic profile like? Is there insulin resistance that we can be treating? And let's go get aggressive there. And it's just, I'm a little bit, my eyes are open to a blind spot.
Yeah.
I'm a pretty self-aware, I'm a pretty observant person, but, I only can see what I can see. And that was definitely a blind spot for me. It was also a blind spot to kind of overlook, in a metabolically pristine person, trivial elevations in cholesterol. I definitely took a more watchful waiting approach, but I also didn't have the ability to have this kind of granular detail as to what is actually going on. I had to kind of project and hypothesize and extrapolate what I think might be going on. And clearly, often enough that it's changing the way that I'm practicing has shown me that that was not fully accurate thinking, and I need to be tighter in my thinking. And the two areas where the greatest opportunity that happened to be my two vulnerabilities, trivial, like a mild elevation in ApoB particle number, it's too high.
Yeah.
My numbers were over 90. I need them way under 90. And my blood pressure always was 138, 142 over low 90s, which is not scary, but it's way off. And so those need to come down, and I'm applying that now to my members. I just think those are the two opportunities that for me are going to change the back half of my life, and I am convinced that it will help me be a more effective physician for the people who entrust me to be their health advocate.
Oh, I love it.
To be just that much better. How has this affected you in the way you're practicing?
Well, I think you touched on it greatly, which is trending out the data is really important. We check ApoB particle number on our members routinely, right? So we have the ability to trend that out. We have gone back and looked at, when members come in for their annual physical, or it's a 90-day check on their lipid panel, where's that ApoB trending? Is it trending up? Is it trending down? How close to goal are they? So, really just being aware of that one metric is really important. And then helping them understand their blood pressure numbers. Obviously hypertension cannot be diagnosed with one blood pressure alone, but we have them just like you did. I mean, you got an automatic blood pressure cuff, and you were checking it in the morning and a couple times during the day, maybe a nighttime reading. I mean, I don't think you were obsessed with it.
No.
But
a couple times a day I was looking.
Yeah, but you were able to have objective data on where it's at.
Yeah.
And sometimes we see that it's normal in the morning, but as the day goes on and members are stressed with their jobs or, things going on, that it elevates at different times of the day. So we're kind of, able to check that out as well. So, really it's, again, going back to being critical with the data and unemotional with it, and just taking it all into consideration of where we can make changes.
And look, that's not easy for everyone.
No.
I'm a very highly emotional, highly passionate. I'm like a blend. I have this scientist, like, just give me the data side of me. And then I have this incredibly passionate, emotional side of me. And they coexist. And I live in the white space between those two things. And when it comes to making decisions about your health, adding medicines, risk stratifying, if you have any part of you that is an emotional, you tend to lead with emotion in those types of decisions, like, this probably is one of those things.
Yeah.
If you ask me to make critical decisions about my children or my wife, it's going to be emotional. That's why I'm not their doctor.
Right.
I can't think straight.
Yeah.
I'm too emotional. I'm too attached. And this was for me. In hindsight, I should have started all of this about 6 months ago. But it took me that long to get through the emotional side of the house to land on, okay, it's not right, wrong, good, or bad. It just is. Like, it's about risk, probability. And if I want to de-risk my future, I can't ignore the thing that is looking right at me,
right.
Especially since I now have unequivocal evidence that I'm absorbing risk.
Yep.
Actively, right now, being mildly hypertensive, keeping these cholesterol numbers where they are, you've absorbed this much risk at the 48 and 3/4 mark.
Yep.
And I'm like, because I have ambition to live over 100. I better do something about this.
Yeah. All gas, no brakes. Do it.